Hi, everyone. Welcome. I'm so sorry for the delayed start this morning. As you would expect for our first virtual advocacy workshop, we are going through the technical challenges that I know many of you and your organizations have faced, but we'll get there and it's going to be a great meeting. I am Jody Hoyos, the Executive Vice President of the Prevent Cancer Foundation, and welcome. Thank you all for being here. We are the foundation for 35 years, almost 35. We actually celebrate our official anniversary in December, has been laser focused on the mission of saving lives across all populations through cancer prevention and early detection. And we could not achieve that mission without this community. So thank you for being here. And thank you especially to our sponsors for today. We have Pfizer, Genentech, Guardant, Daiichi Sankyo, Novartis, and Foundation Medicine. Thank you to each of you. Advocacy is an enormous part and a pillar for how we support our mission. The foundation empowers people to help themselves and their families seek out the cancer screenings and vaccinations that they need, to make healthy lifestyle decisions, and to know their family history for cancer and other diseases. We also advocate for change and policies to support cancer prevention and early detection, protect funding for cancer research, and ensure access for quality care. As you know, the reason that we're here today is that advocacy is needed as it relates to genetic and biomarker testing. We want to make sure that people with hereditary and somatic conditions have access to the tests and the treatments that they need. And despite amazing breakthroughs in the area of testing, unfortunately, patients are still facing financial and access barriers. So we have an opportunity to talk about that together today, talk about those challenges, and think about a constructive path forward. So I look forward to that discussion. And I want to thank the organizations that are here with us participating, and thank you for all the work that you do for patients. I'm going to grab my list because I don't want to leave anyone out. But we have Force, Longevity, the Ohio State University Comprehensive Cancer Center, the Cammie K. Preston Hereditary Cancer Foundation, Innovative Policy Solutions, and Guardant. Thank you. And now I'd like to introduce Jennifer Nyangota. She's our Vice President for Development and Marketing, and she's going to give you a preview of today's workshop.
Welcome, everyone. As Jody said, my name is Jennifer Nyangota, and I'm the Vice President of Development and Marketing for the Foundation. I'm likely a new face to many of you, and I look forward to meeting you today and participating in a great discussion. It's a privilege to be in such great company. The work that you do every day ensures that patients have access to screenings and early detection services. As Jody mentioned, advocacy is a founding principle of ours at the Foundation. We are dedicated to removing barriers to ensure that everyone has access to the care that they need. Our goal today is to have a candid discussion about the current landscape of genetic and biomarker testing and highlight the challenges that people face when seeking care. In addressing these shared concerns, we will look for opportunities to collaborate so that together we can increase access and utilization of screenings. So for today, we'll begin. Our first session will provide an overview of the relationship between genetics and cancer prevention. Next, we'll have a panel discussion focusing on access barriers to testing and their impact on patients. We'll take a short break, and then when we return, we'll have our breakout sessions. You should have received an email this morning with a link to access your assigned breakout session, but we'll also put those links in the chat box below before our transition this afternoon. We'll end the day with each group having the opportunity to report on the priorities that you discussed within your group, and we'll all vote. We'll vote on the issues where we can make the biggest impact together. A little bit of housekeeping. Everyone will be muted for the presentations, but if you have a question, please use the Q&A box below, and we'll send your questions over to the speakers. Now, I'd like to introduce our first speaker, Heather Hampel. Heather is a professor in the Department of Internal Medicine and the Associate Director of the Division of Human Genetics at Ohio State University. He coordinated the Columbus area Lynch syndrome study that determined the frequency of Lynch syndrome among newly diagnosed patients with associated cancers. She is the principal investigator of the Ohio Colorectal Cancer Prevention Project, a statewide study to identify patients with hereditary cancer syndromes and provide cascade testing to the at-risk family members. Again, thank you for joining us today, and I look forward to a productive conversation. Heather, the stage is all yours.
Thank you so much. I'm really excited to be here and to set the stage for this great day we're going to have. Before we start in our panel discussion and our breakouts, we felt it'd be good to kind of talk about cancer genetics, genomics 101. Kind of hit the basics and the differences between what we consider germline genetics, or mutations someone is born with that give them an increased risk for getting cancer, and somatic genetics, which are mutations that are acquired during our lifetime and cause an increased risk for cancer. Okay, so here's my Twitter handle. I've been trying to get better at social media, so if you have any questions, comments, or want to tweet about the presentation, please feel free to use that. And we will go ahead and get started. Hopefully Brendan can work on my echo while I go ahead and start. So I'm going to take you guys on a walk back memory lane to your last biology class, where you probably learned about our genetic material. We now think from the Human Genome Project that there are about 20,000 genes in our body. And they're strung along these 46 chromosomes that you see here, where you get one from mom and one from dad, and so they come in pairs. So each gene codes for one substance or protein that your body needs to grow and develop properly. And many of these genes have a role in how our cells divide, how our cells repair damage that occurs during our lifetime, and other important processes that keep our cells growing nice and slowly, dividing when they should and dying when they should. So next slide, please. Now I want to talk through the different types of mutations. So on the right-hand panel, we're going to go through what inherited cancer syndromes look like. And on the left hand, we're going to talk about what we consider sporadic cancer that's not inherited, but it also may have mutations that are acquired, not inherited. So the inherited ones on the right, basically what happens is if this is a cartoon drawing of the two chromosomes, one from mom and one from dad, if somebody inherits what we call a pathogenic variant in one of these cancer susceptibility genes, like the orange copy on the left, that copy is not working in every cell of your body from the day you're born. And it can't do its protective function, whether that's involved in repair or some other role in keeping our cells growing at a nice normal rate, dividing when they should and dying when they should. But the good news is your other copy from your other parent will be working properly, because it's pretty rare for two people to get married who both have one of these mutations. So generally, you inherit a mutation from your mom or your dad, not both. And from the other side of the family, you get this working copy. And that working copy is going to compensate for many years, and everything will go along fine. So with most of the inherited cancer syndromes, we don't see childhood cancers. They're more adult onset cancers, because for many years, that working copy from your other parent will have that protective role, and your cells will divide when they should and die when they should. The trouble is, with millions of cells in our body and in our at-risk organs, the odds are pretty high that just by bad luck over the years, or maybe aging or exposures, you might acquire a mistake in that working copy from the other parent. Now you have a cell that has no more of this protective gene. And that cell can then start to accumulate mistakes, which it can't fix, eventually start to grow funny, not die when it should, and that cell becomes the cancer. So in these inherited cancer susceptibility syndromes, it's sort of like being born one step closer to getting a cancer, because of having that one genetic mutation in every cell of the body from the day someone's born. And then all it takes is for that second mutation to occur during someone's lifetime, and that's when we can see a cancer develop. So family histories and inherited cancer syndromes tend to look much stronger, where you can see in this case, we draw family trees like this in cancer genetics. This is the grandma, the dad, a paternal aunt, and a daughter who all have had cancer. So you can tell because they've been shaded in that they've had a cancer. So what you're seeing here is 3-generation family history of cancer. And that is a red flag that it might be hereditary. This is something we consider a vertical transmission pattern where you can see it getting passed down through the generations. And that's a red flag that a family history could be hereditary because you can sort of feel that gene that's not working getting passed down through the generations. But not everyone inherits it. You'll see this with unaffected uncle as well. And we'll talk about that in a minute. Again, because the person is born one step closer to getting cancer, it doesn't take as long on average. So in these inherited cancer syndromes, we see earlier ages of diagnosis. Generally, anything under 50 is considered early. We can see people who've had more than one primary cancer. So here I'm not talking about metastases or recurrences of a first cancer. I'm talking about different unrelated cancers or bilateral cancers in the case of paired organs of the breast. If someone gets a breast cancer in their right breast and 10 years later has a new primary breast cancer in their left breast, that's a red flag that there might be an underlying susceptibility to cancer. And then clustering of certain cancers, and I think people are very aware in 2020 that breast and ovarian cancer can run together in families. I think there's a growing awareness that you can also see prostate and pancreatic cancer in the breast ovarian cancer families. I think what lagged behind is awareness about Lynch syndrome, which we'll talk about today. And that's a syndrome that causes colon, uterine, ovarian, and stomach cancers to run together in the family. And I don't think it's that as well known or intuitive that those cancers can be related. So if somebody with an inherited cancer syndrome, you can take a sample of their blood or their saliva or even a skin punch biopsy, and you should find this mutation that they inherited from their mom or their dad in all of those cells. And so that's the way we would test for these, what we call germline or inherited mutations. And the reason they call them germline is the germ cells are our egg and our sperm, and that's where these are inherited from, our parents' egg or sperm. So the flip side are acquired mutations that happen during our lifetime. And even in the inherited one, there's an acquired mutation. That second hit is acquired. And there are probably additional mutations that occur after the second hit. But in the case of sporadic cancers, the person wasn't born with any of these cancer genes not working. They did not inherit from the egg or the sperm that made them, from their mom or their dad, a mutation in any of these cancer genes. So they had them all working to begin with. But as they aged and their cells divided, they might have acquired a mutation in a cell. This is a normal part of the aging process. Probably that cell died, nothing came of it, but if a cell lives long enough and acquires enough mutations, that cell can get some sort of growth advantage and develop into a cancer. So this is a much more multiple step process. We can see, tens to dozens to hundreds of mutations in some tumors. It's going to take place over years. So we tend not to see a strong family history. It's kind of a cancer that pops up in somebody without a strong family history. We can see average to later ages of diagnosis for these sporadic cancers and single or unilateral tumors. Again, just one cancer in a person's lifetime, not multiple cancers during the person's lifetime. If you tested the blood from somebody with these acquired mutations, you wouldn't see these mutations unless they had a blood cancer, right? So these mutations only occur in the tumor. So you usually get a piece of the tumor to do the testing, with the exception of liquid biopsy, which we're going to talk about in a little bit, which gives us some possibility of finding these circulating tumor cells or DNA from tumor cells in the blood. But typically, if you do testing for an inherited mutation, you would use blood or saliva. And if you're doing testing for a somatic or acquired mutation, you would use tumor tissue. Next slide, please. In the inherited cases, they're inherited mostly in a dominant fashion. So if you remember Punnett squares from back in biology class, somebody's mom, in this case, has a mutation in one of these cancer genes. Again, their dad would likely not have a mutation in the same gene. And when they had children together, there were 4 possibilities. which boils down to a 50% chance that the child will inherit the mutation from mom. They only get the working copy from dad, but in this case, they would inherit that increased risk for cancer and would need intensive surveillance and prevention options because of their higher risk for getting cancer. But it's equally likely that their mom can give them their working copy. Dad, again, only has working copies to give. And if this happens, the child has not inherited the hereditary cancer syndrome that's running in their family, and their risk for getting cancer is the same as anybody else in the general population. They don't need intensive surveillance. They can follow the general population guidelines for cancer screening. So this is quite powerful information for the families where we can find an inherited cancer susceptibility, because we can let the at-risk individuals know whether they did or did not inherit the mutation that causes the increased risk for cancer in the family. And if they did not, they not only don't need the increased surveillance themselves, but they cannot pass it on to their children or their future children. It will stop there in that branch of the family. So this can be very powerful if we can find the genetic cause in inherited cancer families. Also, I just want to point out, and this we're going to allude to a little later, but if you look in, again, the blood, saliva, or any of the cells in a person with an inherited mutation that they got from their mom or their dad, it should be in about 50% of their DNA. And the reason for that, right, is that they have the one copy with the mutation from their mom, but they have a working copy from their dad. So 50% of the DNA will have the mutation in it, and 50% of the DNA will not. And that can be utilized later when we look at some of the tumor testing to help us distinguish, not 100%, but it gives us a good indication if a mutation that's found in the tumor might be possibly inherited, or if it's more likely that it was acquired during an individual's lifetime. Next slide, please. And so the mutations that are acquired during a person's lifetime are in the tumor, as I mentioned, but they're not in every cell of the tumor. So tumors are really heterogeneous. They have lots of different things going on. So you start with sort of a normal cells in an organ, and maybe one of them acquires a mutation. Again, maybe nothing comes of this, but maybe as it divides, it acquires a second mutation. Now you have a population of cells with one and a population of cells with two. Again, that one with two can go on and acquire a third. Now you've got populations of cells with one mutation, populations of cells with two, and populations of cells with three, and so on and so forth. So that tumors are very heterogeneous, and the mutations that occur that are acquired during a person's lifetime that are driving their tumor are usually in much less than 50% of their DNA, because they're only in some of the cells of the tumor. We also never can get 100% pure tumor. I'll show you in a minute what a tumor block looks like. The tumors tend to have a lot of normal adjacent cells. They even have blood vessels in them and lymphocytes, normal cells, which are not going to have these acquired mutations. And so you tend to see acquired mutations at much lower than 50%. The general rule of thumb is usually less than 35%, because they're only in portions of the tumor cells. And they certainly aren't in any of the normal cells that are used for the DNA extraction for tumor testing. Next slide, please. Okay, so here, this is very small, but if you've never seen a paraffin block, this is what it looks like. If you have surgery at a hospital, they keep actually a small piece of your tumor in a wax block on a plastic cassette in the pathology department. The reason they do that is historically has been really for confirmation of the diagnosis. If there's ever any doubts about what the original diagnosis, that can be pulled and looked at again. But it turns out it's actually quite helpful, because you can extract DNA from the tumor to do genetic testing. And so what you see on the left here is what we call an H&E slide. So they take a thin slice of that tumor and stain it so they can look at it under the microscope, and that's what you see here on the right. And a pathologist can say, okay, well, this part of the slide up here has tumor in it. This part of the slide does not. So then they'll circle that part that has the tumor, and that's what they'll scrape off or try and obtain from the block, so that they've got as much tumor as possible and as little of the normal adjacent tissue as they can. So this emerging model of cancer treatment, which we're going to be talking about a lot today, is to get that tissue and look for mutations that are in that tumor that can help you select your therapy. And so it is really a more personalized medicine where we're trying to choose treatment based on the mutations that are driving the cancer, and less to do with what organ your cancer has to happens to be in anymore, and more what the underlying cause of that cancer is, which is a much more targeted treatment approach. So this is, and these mutations are often referred to as biomarkers, mutations that you find in a tumor that can give you an idea of what therapy to use that might be effective. Next slide, please. So some differences, big picture, between somatic and germline variants that we've been talking about today. Germline variants are in essentially every cell in your body. Somatic variants are in your tumor cells. Germline variants are in about half of your DNA because you got them from your mom or your dad, so it's 50% of the DNA. But the somatic or acquired mutations are usually in less, maybe less than 35% of the DNA in your tumor specifically. Germline testing uses blood, saliva, or skin. Somatic testing uses tumor tissue acquired through biopsy or surgery, or we can also look in the blood if you have very detailed testing that can look for either circulating tumor cells or cell-free DNA, pieces of the DNA from the tumor that have been shed from the tumor and are circulating in the bloodstream. So that can give you, these last pieces are what's known as a liquid biopsy, when you use blood to try and find some of these tumor mutations. Next slide, please. Just to go through some of the most common hereditary cancer syndromes briefly. The two most common hereditary cancer syndromes are hereditary breast ovarian cancer syndrome. That's due to mutations in the BRCA1 or BRCA2 gene. Lynch syndrome is, I mentioned earlier, is the most common cause of colon and endometrial cancer. And it is due to mutations in actually 5 different genes: MLH1, MSH2, MSH6, PMS2, and EpCAM. And those two conditions are so common and really actionable. There's a lot that can be done in terms of intensive screening or prevention to keep people from getting cancer if they have one of these conditions and they know about it. And the testing is so good that the CDC now considers those two conditions tier 1 conditions. In other words, they're really a public health problem, and we need to start thinking about getting people identified with these conditions in a much more aggressive and broad way. There's one other tier 1 condition, it's not a cancer condition, it's called familial hypercholesterolemia. That's a hereditary high cholesterol condition that is also common and actionable. And those 3 conditions together have been considered the sort of classic tier 1 conditions by the Center for Disease Control. A couple of studies now have done genetic testing in healthy, unselected individuals. There's a nice study from Healthy Nevada Project that found the exact same results as Geisinger found in their MyCode project. And basically, these are genetic testing programs where testing is offered to anyone, regardless of their family history. And they actually have found that these 3 conditions are in 1 in 75 individuals, which is unbelievably common. And compare that just for a minute to the newborn screening program. So, you know, when you have a baby, they usually do a heel stick and do a series of genetic tests for what they've considered actionable in childhood genetic conditions. That program, the positive rate is 1 in 800. So we've decided that's important enough that every United States needs to have that testing. Yet we haven't really tackled testing the general public for these 3 tier 1 conditions that affect 1 in 75 of us. So it's something I think we need to start thinking about. We can talk about in our breakouts this afternoon. Next slide, please. So hereditary breast and ovarian cancer, as I mentioned, due to BRCA1, which is on chromosome 17, and BRCA2 on chromosome 13. These were found in 1994 and 95, and testing became commercially available in 96. So we know a lot about these genes today. Next slide, please. The cancer risks are slightly different for the 2 genes, but definitely include increased risk for breast cancer, second primary breast cancers, and for that reason, some newly diagnosed breast cancer patients like to get tested before they decide about their surgery because they might want bilateral mastectomy instead of a unilateral mastectomy or a lumpectomy if they knew they had this very high risk for a second primary cancer. Ovarian cancer risks, and we can see other cancer risks with BRCA1, including prostate cancer. Next slide, please. BRCA2 is generally considered to have a wider tumor spectrum. It has a little lower ovarian cancer risk, similar breast cancer risk. But here we see male breast cancer, pancreatic cancer, melanoma, and certainly prostate cancer are significant increased risks with BRCA2. Next slide, please. The management guidelines that we tend to use for families with BRCA1 and BRCA2 mutations or Lynch syndrome at Ohio State are what are called the nccn guidelines. And we'll be talking about those guidelines in the breakouts this afternoon. This is the National Comprehensive Cancer Network, and it's a group of experts that get together at least once a year, sometimes more often than that, review the data and make expert recommendations for how to manage a patient with these conditions. The only difficulty with that is they can change quite a bit from year to year, depending on who's on the panel and the weight that's given to different studies. And so you kind of have to stay up on these closely. But the bottom line, I won't go through this all in detail, is that there is very good, proven effective surveillance for individuals with hereditary breast ovarian cancer that start with things like annual MRI at age 25, adding on the annual mammogram at age 30, consideration of risk-reducing mastectomy, and medications that someone can take to reduce the risk of breast cancer. Next slide, please.
Since there's not really any proven effective screening for ovarian cancer, most women with hereditary breast ovarian cancer eventually elect to have their ovaries and fallopian tubes removed with or without a hysterectomy. And it's tended to be recommended a little earlier for BRCA1 carriers, around 35 to 40, and a little later for BRCA2 carriers, 40 to 45, given the lower risk with BRCA2. Women can try birth control pills to lower the risk of ovarian cancer. Again, no proven screening, but there is some screening that can be tried if a woman's still putting off surgery for childbearing purposes. Next slide, please. For men, we also talk about screening for male breast cancer. And there is prostate cancer screening actually recommended at age 40 for BRCA2 mutation carriers and as a consideration for BRCA1 mutation carriers. Next slide, please. For other cancers, melanoma, there's not specific guidelines, but certainly full body skin exam is not invasive and an easy enough thing for individuals to add. They did just this year add pretty extensive pancreatic cancer screening guidelines for individuals with BRCA1 and 2 mutations, but also Lynch syndrome, which we'll talk about in a minute, and some other mutations that have been shown to increase the risk of pancreatic cancer. But for almost all of these, you would have to have the mutation plus what we consider a first-degree relative, a parent, sibling, or child who has pancreatic cancer to have a high enough risk to attempt pancreatic cancer screening. It's a newer screening test. There is some promising data, but it's still considered a bit experimental. And for the rest of the cancers, including colon, it's generally recommended that individuals with BRCA mutations just follow the American Cancer Society guidelines in the general population. Next slide, please. This testing has changed quite a bit over the years. As I mentioned, we started by sequencing just the BRCA1 and 2 gene. And what that is looking at the DNA code of those 2 genes and looking for any spelling errors. At some point in 2002, they realized that this would miss large rearrangements in the gene. So if a huge chunk was missing or a huge chunk had been added, that's not detected when you're checking the letter code of the DNA. And so they added from 2002 to 2006 the 5 most common large rearrangements, which all happen to be in BRCA1. But that meant if you had the 6th most common large rearrangement or the 600th most common large rearrangement, you could have a false negative test because it would not be detected on the testing that was available at that time. From 06 to 13, you could opt for an add-on test that would look for any of the large rearrangements but it cost an additional $750, and insurance companies tended not to want to cover that because they had just paid several $1,000s to check the same genes. So a lot of people that were tested during that time period still just had the 5 most common large rearrangements and not the add-on rearrangement test. And then from 2013 till now, we've really moved to broader, what we call multi-gene panel tests that include dozens of genes that increase the risk for breast, ovarian, and other cancers, including BRCA1 and 2. And this testing luckily has enough depth of coverage that it does detect any of those large rearrangements in the gene. But I just want to point out that what this means is that women whose test did not include panels or all the large rearrangements could have tested negative previously and actually still have a mutation in one of these genes that was not detected. So they may need to have their testing repeated if they have had a strong family history and their test was not complete. Next slide, please. So just to give you some panel results, to give you a sense of how panels have changed things for us in germline cancer genetics testing, and these panels are also used for somatic testing. It's where you look at multiple genes at the same time for much lower cost, and it's really enabled this whole technology to kind of become so much more commonplace, more accessible, and less expensive. So this is the largest study looking at unselected women with breast cancer. There's 35,000 women with breast cancer who underwent panel gene testing for 25 different cancer susceptibility genes, and 9.3% tested positive. Half had mutations in BRCA1 or 2, so those are the most common breast cancer susceptibility genes, but half were in other genes like CHEK2, ATM, and PALB2. As you might imagine, the younger women at diagnosis were more likely to test positive, older women were less likely to test positive, and between 40 and 59, it stayed right around that median of 8 to 9%. Next slide, please. When you look at unselected ovarian cancer patients, you actually find the highest mutation frequency of almost any cancer. And this is why for many years they've recommended that every single ovarian cancer patient undergo germline genetic testing. And increasingly they're undergoing tumor testing as well, which we'll talk about in a minute. But here you could see that in this large study of 360 unselected ovarian cancer patients, 18% had a mutation in BRCA1 or 2. So again, clearly the most common gene mutations causing ovarian cancer, but 6% had mutations in another cancer susceptibility gene. And you see just all kinds of different genes here that have been linked with ovarian cancer. So again, if you just had BRCA1 and 2 testing, could have missed any one of these gene mutations. Next slide, please. Just briefly, the reason this has become much more exciting lately for those of us who work in inherited cancer genetics is that there are now treatments that seem to work better for people who do have mutations in these genes. So PARP inhibitors, for example, back slide, please, Brendan. PARP inhibitors have been shown to be very effective in treating women who have BRCA1 or 2 mutations. And it doesn't matter whether the BRCA1 and 2 mutation was inherited or acquired. So you often have to check both the blood or saliva for inherited mutations, but also the tumor, because either way, if BRCA1 and 2 are inactivated, PARP inhibitors seem to be a very effective treatment. I won't go through the whole process here, but if you want to look at this slide more carefully later, you can. And this looks like it is effective for any gene in this same pathway as BRCA1 and 2, which are involved in what we call homologous recombination deficiency pathway. So lots of different gene mutation carriers could benefit from this treatment, and it doesn't matter if they inherited the mutation or it was acquired during their lifetime, this kind of treatment should be effective. Next slide. Switching syndromes, and I never give myself enough time for Lynch syndrome, which is where I spend most of my efforts and research, but here you can see the 4 main genes pointed out. Next slide, please. It is expected that about 1 in 279 individuals has Lynch syndrome. If you take that times the population, that's 1.2 million people in the US. Causes a high risk for colon, uterine, stomach and gastric cancer, as I mentioned, and these are very preventable cancers with earlier and more frequent screening or, again, risk-reducing surgeries. But it is estimated that 95% of people with Lynch syndrome are not aware of their diagnosis, so we have a very long way to go into getting more people diagnosed. And this isn't much better than hereditary breast ovarian cancer, which is probably around 90%. Next slide, please. The cancer risks are elevated for colon, uterine, stomach, and ovarian, and it varies on what the underlying gene is. 2 of the genes have much higher risk than the other 2, but all of them are elevated. Next slide, please. There are NCCN guidelines for this syndrome as well that begin with colonoscopy as early as age 20 to 25 and every 1 to 2 years, or for the lower risk genes starting at age 30 to 35. Screening for uterine cancer or consideration of hysterectomy with removal of the ovaries and tubes can also take care of the ovarian cancer risk. All of the other screenings have to do with whether those cancers have been seen in the family or not. So stomach cancer screening only if there's been stomach cancer in the family. Next slide, please. Urinary tract cancer screening only if it's been in the family, or particularly for MSH2 mutation carriers in males with MSH2 mutations. Next slide, please. Panel results of 1,000 colon cancer patients found that 9.9% of colon cancer patients have a mutation in 1 in 25 cancer genes. A third of them have Lynch syndrome, but really 2/3 have mutations in other genes, not Lynch syndrome. Could be colon cancer genes, could be genes that have not previously been associated with colon cancer, moderate risk colon cancer genes. So a very significant likelihood that there will be a mutation in a colon cancer patient. So we're just wrapping up. The treatment for Lynch syndrome patients uses immunotherapy. So this has been the very exciting finding that patients with defective mismatch repair benefit from immunotherapy no matter what their tumor type. Again, they don't have to have Lynch syndrome, but most people with Lynch syndrome do have defective mismatch repair. But other people can have defective mismatch repair and will benefit from immunotherapy. So this is the piece now where it's become common that people want to test tumors for this mismatch repair deficiency to see if immunotherapy might work. And we have to keep in mind that anyone who has deficient mismatch repair needs referred to genetics because they are more likely to have Lynch syndrome. Next slide, please. Next slide. So tumor testing options vary from just looking at specific mutations like the BRAF V600E mutation, and these are the kinds of things you'll see available internally at your own hospital, to these big panels that you hear of, which will have hundreds of genes on them. And there are several FDA-approved tests at multiple of the testing laboratories, even our sponsors today, which we can talk about later as well during the panel. In liquid biopsy, the exciting thing here is that it has potentially a role in early detection. So these cell-free DNA from tumors could be circulating in your blood, and that might be a way to detect a cancer in the first place. The other thing is it can screen a cancer over time to see how it's responding to therapy, whereas you're not going to want to get biopsied multiple times over, the course of your treatment because biopsies are invasive and unpleasant and you have to heal. Giving a blood sample is an easy thing to do. And so there's a lot of excitement around the liquid biopsy options for that reason. Next slide. And I think we're running out of time, but I think I've alluded to this earlier that you can, when you do a tumor test, some of the labs include germline testing, some of them do not specifically. But if there is a mutation in that you were born with, it will be in the tumor just like it'll be in your blood or your normal cells. And so sometimes you can look through a tumor test and certain things will be a red flag that a mutation that was found in the tumor might have been an inherited mutation. One of those has to do with what proportion of the DNA the mutation's found in, which we've talked about earlier. If it's found in 50%, that's a soft sign that it could be an inherited mutation. Next slide. Next slide. So take-home messages is that all cancers are genetic. There are gene mutations in every tumor. But not all cancers are hereditary. About 10 to 24%, depending on the tumor type, are hereditary, and that's when they're due to a mutation that was inherited, a germline mutation that came from mom or dad. Germline testing is designed to detect any mutation in a cancer susceptibility gene. So it's going to look for those large rearrangements. It's going to sequence the gene. There are difficult genes that need special testing. It is unlikely that any germline test will detect a tumor mutation unless there's a lot of circulating tumor in the blood. Tumor testing is designed to look for actionable therapeutic targets. So it can detect germline variants, but it can also miss them. Therapy is effective whether the variants are in the tumor or the germline. So you might need both tests. You might need your tumor tested and your germline tested because if the mutation's found in either, you could benefit from the treatment. And liquid biopsy is an exciting new way to test tumors, which may lead to new tumor screening options in the future. Thank you very much. Next slide, Brendan.
That was a great presentation. If anyone has any questions for Heather, feel free to put them in the Q&A box. But until then, Heather, I just thought that I would throw out a question to you first and just kind of say from the perspective of prevention, when you're speaking with patients, what is some of the way that you feel is the best way to kind of break the confusion between, somatic testing, hereditary testing? There's just so many terms that folks have issues with, and even some, professional folks don't necessarily know the difference as well if they don't really know much about genetics or genomics. And so my question is just, what do you kind of feel is the best way to present this information to patients?
That's a great question. And I think it has been causing a lot more confusion lately because sometimes, when we're seeing a patient about their family history and mention genetic testing, they'll say, oh, I already had that. But what they had, in fact, was testing of their tumor to look for targeted mutations for therapy. So I tend to like to talk about the mutations you're born with versus the mutations you acquire during your lifetime. And I think people really understand the difference between those two. And that we sometimes need to do both tests, both a germline test to look for the mutation someone might have been born with that they inherited from their mom or their dad, and a tumor test to look for any mutations that they acquired during their lifetime that are driving their tumor. Because if they got the mutation either way, it still indicates that they might benefit from that targeted therapy. And so it's important to check both oftentimes. So I try to kind of keep the two separate. And while each test has a potential of detecting the other mutations, like you can occasionally pick up a germline mutation on a tumor test, that's not what they're typically designed for. And germline tests can occasionally pick up a tumor mutation if there's enough tumor in the bloodstream. That's, again, not what they're designed for. And so really you need to have the right test, as they always say, for the right person at the right time to try and prevent those cancers.
Right. Any other questions for Heather? Well, and not receiving any more, I'll go ahead and say thank you to Heather. We really appreciate you giving us this great information, and we know that you're going to be joining us on our panel, so we'll get to hear even more of you.
I'm Brandy Preston. I am the founder of the Hereditary Cancer Foundation. I started it 5 years ago in memory of my mom. She was diagnosed with breast cancer at 35 and again at age 38 and passed away in 2005 at the age of 40. I was 14, my brother was 13, my sister was 9. And 3 days before she passed away, she made each one of us kids promise that we would be tested, we'd know our risk, and we'd do something different about it. So I was tested on my 19th birthday. I'm in Nebraska. That's our legal age of consent here. And I'm BRCA1 positive. So I have that, like Heather was explaining, the BRCA mutations. I have a lifetime risk, 87% lifetime risk of breast cancer and a 63% lifetime risk of ovarian cancer. So at 22, I did a bilateral mastectomy and reconstruction. And then I'm 29 now, but when I'm 35, I'll remove my ovaries and hopefully won't have to worry about any of those cancer risks anymore. I really believe that knowledge is power. So when I started our nonprofit, we pay for testing whenever it's not covered by insurance, Medicare, Medicaid, or for people that have high deductible plans. The Affordable Care Act has done a ton for this space, especially when it comes to BRCA testing. We have some work to do when it comes to Lynch syndrome or men. They aren't covered under the Affordable Care Act like women are. Medicare obviously is a struggle. And then those high deductible plans for men. So that's kind of where we come in, and I'm excited to be here and to be part of this panel. Oh, Becky, we can't hear you.
Brandy, can you hear me now?
Yes.
Yes.
Oh, wonderful. Okay. Our apologies for the technical difficulties, folks. Okay, Becky, you need to probably unmute yourself. Are you unmuted? Why don't we move on to Nikki while she figures that out? Nikki, go ahead and share a little bit about yourself.
Can you all hear me okay?
Yes.
Excellent. So hi everyone, my name is Nikki Martin and I work at Longevity Foundation. We are a patient advocacy group and we focus on lung cancer. And I am the director of precision medicine initiatives, which really means that I'm running a lot of our programs that address patient awareness and access to biomarker testing, which Heather referred to as tumor testing. It's the same thing. But I'll be speaking today about a pan-cancer effort that many of the organizations that are speaking and also probably listening in on today's conference have been involved in to get more consistent common terms circulating for patient education about testing, whether we're talking about testing for the inherited mutations or testing for the non-inherited mutations. I'll be talking a little bit about language as a barrier to patient education and awareness and what some of us are doing to try and address that.
Thanks, Nikki. And Becky, let's try again.
Can you hear me now?
Yes, thank you.
Hey. Hi, everybody. I'm Becky, also a genetic counselor by training. So it's fun to be on the panel with some familiar faces here. I started in the germline space and about 5 years ago moved over to the somatic space in a laboratory called Guardant Health, who is doing the liquid biopsy testing that Heather mentioned earlier. So I also cross paths with people in Nikki's world, because a lot of what we're working on in the somatic testing space is how do we make sure patients have access to easy, rapid testing for biomarkers that would allow them to get targeted that might be more effective than chemotherapy or other options. Guardant Health has one test on the market currently, which is kind of a therapy selector in the metastatic cancer setting. But we are working on early stage products, so looking at molecular residual disease in earlier stage patients, and also using that as a monitoring tool, almost like a tumor marker, like a CA-125, to monitor patients' cancers over time. And then we have another product coming hopefully sometime soon in the future where we will be able to use ctDNA to do early detection. And we currently have a 10,000 patient colon cancer study that was launched across the country called Eclipse, looking for colon polyps and colon cancer in average risk patients. So lots of exciting new things on the horizon for liquid biopsy. And I'm really excited to be here today because a lot of the work that we're doing in this space, we're really forging a path forward because this is a new technology. As Heather mentioned, most of the time, historically, this type of testing was done on a tissue sample. And so this new non-invasive way of identifying somatic tumor mutations is still somewhat new. And so there's a lot of work to be done in terms of getting reimbursement for this, as well as making sure patients get the adequate testing that they need. So happy to be here. I had a video I wanted to share. I'm not sure with our technical difficulties if it's worth the risk of running it. So Brendan, we can skip that. And I'll let the next person go.
Lisa, we lost you again.
Okay, great. I was saying, our apologies for the technical difficulties. This is all, you know, something that's par for the course with our COVID adventure here. And if we have time later in the day, perhaps we can key up the video from Guardant so our attendees can see it. I'd like to backtrack a little bit and just give us a bit of an introduction about what we're going to be doing here. So our lovely panelists, who've all had a few minutes to introduce themselves, are all active in the genetic and biomarker space. And when we say genetics, we are speaking of genetic testing for hereditary risk, or what we consider hereditary cancers, as Heather shared. That specifically is people who've inherited those mutations from their mother or their father. My name, of course, is Lisa Schlager. I work for an organization called FORCE, also known as Facing Our Risk of Cancer Empowered. And this is specifically our focus. Our organization serves people and families that do, in fact, carry these hereditary predispositions to cancer via either a BRCA mutation, Lynch syndrome mutation, or one of these other types of mutations that was discussed during Heather's presentation. We are also quite active, along with many of these other groups, in the biomarker or tumor testing space, because there's quite a bit of use and utility and zeroing in on what is driving those cancers and finding the right therapy for the right person. So we are excited to discuss some of the new breakthroughs during our panel discussion today. And we're also going to talk about some of the challenges. So now that we've had a chance for everybody to introduce themselves, I'd like to delve in. So we're going to start with a question that each of you will have an opportunity to respond to, specifically with the growth of testing for hereditary cancer mutations, as well as biomarker testing and targeted therapies. You know, they've really fueled personalized and precision medicine, or at least progress in that direction. There certainly is great potential, but there are also many factors that hinder access and efficient utilization or use of the tools that we have available to us. So in your experience, and we'll circle around starting with Heather, what are the major barriers to testing? And if your expertise is in hereditary cancer, that can be what you speak to. If your expertise is in biomarker or tumor testing, please feel free to share your perspectives on that. But specifically, you know, what barriers have you seen? And if there are differences perhaps between the hereditary and the biomarker areas. So Heather, can you share with us your perspective there?
Yeah, great question, Lisa. I think that historically, I guess I would see two main barriers for the germline genetic testing, and one of them is probably shared by biomarker testing. And so that would be cost, of course. So at some point, it was over $4,000 just to check for the BRCA1 and 2 genes. Now, with next generation, that's come down significantly, and we can get large panels of genes, including BRCA1 and 2, for patient pay costs as little as $250. But I think the word is not out that the cost has come down and that it's much more accessible. And sometimes patients don't get referred because their doctor thinks that they couldn't afford the testing. And that's why we see a lot of the disparities we do in underserved populations having access to germline genetic testing. The cost of biomarker testing has not come down as quickly as the germline testing, and so I think that's still an access barrier for that, but I'll leave that to the biomarker people to talk about. Then the other access pinch point, I think, at germline is the guidelines that we're going to talk about in some of the breakouts this afternoon. Some people simply don't meet the guidelines for testing. in which case they may not have coverage at all, insurance coverage of their genetic testing. Also, there's just not an awareness in that case to refer them. And I think it's a little bit inconsistent. For example, we now recommend that every single pancreatic cancer patient get germline genetic testing, and there's about an 8.2% chance that they will test positive. But we do not recommend the same for every breast or every colon cancer patient, and you saw that they have almost a 10% chance of testing positive. So I think now that we have panel data, we may need the guidelines people to step back and look at the big picture and get our guidelines in alignment with the likelihood that a mutation is going to be found.
Great, thank you. That's really great insight. Jennifer, what about you?
Yeah, I think Heather raised a really important point around financial access. And I know in Nikki's remarks, she mentioned awareness, and I think those probably too important. Being able to afford it, and also the awareness both for the patient and providers that this testing is available. But when I think of utilization, it's not just getting access to the test itself, it's what you do or use that information before or afterwards. And I think two of the biggest challenges there have to do around data sharing. One is that what a lot of tests is now are ordered through third-party laboratories. And so if providers are unable to order the test directly through their electronic medical record at their institution, or if they are, they may not be able to access the test report through their EMR. It might be uploaded as a PDF and not where all the other laboratory really simple workflow issues that address could really facilitate patient access to not just their cancer that they might have across their lifetime. So that the Office of the National before the pandemic in February, and just too much volume in other areas, but they did call this out that through EMRs is a huge. Then likewise, just the ability of results, and I don't mean just the report, but raw data, the variant call files from tests, and I know those are huge data sets, and a lot of labs are uncomfortable. But I think for clinical trials, all of your information to see if you have a potential match for a new trial that's emerging or biomarker haven't thought of before. So I'd really like to see the utilization barriers not just be us up front, but afterwards what patients can do with it.
Thank you, Jennifer. So unfortunately, you were dropping in and out a bit, but just to recap, you see some issues with the reporting of the information and getting it into electronic medical records, but also the data sharing potential and its ability to direct people or to match people appropriately with clinical trials and things after diagnosis. Is that a pretty good recap?
Perfect. Yes, thank you.
Great, thank you. Okay, Nikki, what are your thoughts on this?
Sure. So, I mean, I would echo everything that has already been said. Awareness is a big barrier, not just patient awareness, but also on the provider side. I think that in surveys of different provider types, you see like kind of low awareness of certain guidelines that we would really hope that they would turn to understand what's the recommended testing for certain patient categories. We also, in certain disease states, know that tissue acquisition or acquisition of the biospecimen, so the tissue basically that's being evaluated for biomarkers is a barrier. It can be very hard to get the right kind of tissue that is required to do comprehensive biomarker testing for multiple biomarkers at one time. And then also what happens to the tissue or the blood once it's taken out of the patient. So the pre-analytics, what happens before it's being molecularly analyzed, that can also be a barrier if it's not done the right way. If the tissue handling's not done the right way or blood handling is not done the right way, and can lead to false negatives, false positives, or just inconclusive results, which then kickstarts the process again. So there's lots of different barriers, and of course the payers and the cost issues is another barrier as well. lots of things you could be evaluating as that we could be talking about today.
Wonderful. So just to clarify, Nikki, your perspective is generally targeted towards the biomarker space, as you were speaking of tumor testing. But your comment about provider awareness, I think, is across the board, and very much applies also to the testing for hereditary cancer predisposition as well. Becky, so you've got experience with this through Guardant Health and your prior career. What are your perspectives on barriers? Oh, you need to unmute, Becky.
Sorry, guys.
Okay.
Just to drill in on a couple things that you mentioned in terms of healthcare provider awareness, there's some data showing that in non-small cell lung cancer, which is kind of the poster child for somatic biomarker testing, because there's so many biomarkers and so many FDA-approved drugs that it's unclear why you would not do testing in that patient population. We know that only 8 to 30% of patients are getting fully genotyped for those biomarkers, which then means they're going on chemotherapy or immunotherapy, which may not work as well. We know that there's data showing that certain actionable biomarkers indicate a lack of response to immunotherapy. So it's not just telling the patient that targeted therapy might work, it's also telling them that other therapies may not work. And so really important that we continue to educate providers about the importance of that comprehensive genomic profiling. I think the other issue Nikki brought up that fits nicely with kind of the non-invasive aspects of liquid biopsy is the issue with tissue, getting the tissue block, which might have been destroyed, or it might be, out in, say, elsewhere in the middle of the country and you can't get your hands on it, where you have the patient in the office and you really need that information quickly. Blood is a great solution for that because it's just 2 tubes of blood and you get that result back typically within a week. But that's a barrier for sure. And then lastly, I think patients can really be, they're not a barrier, I don't think, but they can be their best advocate. And I think we saw this in the hereditary space as well, that they have to really go to their doctor and not be afraid to ask for these new tests that are available and to really advocate for their best healthcare.
That's a great point. And, I think all of our advocacy organizations do, in fact, encourage self-advocacy, and we try to educate the patients, the consumers, the caregivers about the need to self-advocate when you go in and speak with your doctor. So, Brandy, you're coming at this from more of a patient perspective as well as a nonprofit person. So what have you seen in the way of barriers in your experiences?
Yeah, I think for cost, the Affordable Care Act's done a lot for those in the BRCA world, for people like me that have a young breast cancer. My mom had a young breast cancer. I'm covered zero out of pocket. However, my brother is not covered zero out of pocket. He's subject to his deductible. So I think that barrier between men and women right now is pretty dramatic. I also think right now with COVID, just the lack of access to healthcare providers. I think the stat I've been seeing going around is 80% reduction in cancer screenings for people going in to get a mammogram or get their colonoscopy. A lot of times this is where people are identified as at risk. And so I think our current situation is also acting as a barrier. And to that point, I'm from Nebraska, like I said earlier. So having providers that are aware of what they're even looking for, when we think of Lynch syndrome, we think of colon cancer, but a lot of times you don't think of gastric cancer going along with it or uterine cancer. And those definitely do go along with Lynch syndrome, or with BRCA. Sometimes people don't correlate pancreatic cancer. Looking for those cancers is really important to help identify if there's a mutation and possibly in that family. And I think we need healthcare providers to be more up to speed on the guidelines so they know who's appropriate for testing, and maybe offering that testing when it's available. In rural Nebraska, there is no genetic counselors. So having your primary care provider being the person having that conversation, in my eyes, is really important. And then you go on and talk to a genetic counselor if you're positive or if you're high risk, but just improving that access across the board. Like Heather said earlier, I think we're seeing that these mutations are more common than what we've been thinking before.
Thank you. Thank you for that. You pointed out a couple of really important issues that I'd like to build on. So first, you mentioned that under the Affordable Care Act, you were, quote, covered at 100%. And I want to clarify for the folks joining us today that the U.S. Preventive Services Task Force guidelines do, in fact, guide what preventive services are covered at 100% under the Affordable Care Act. And the task force gives a letter grade B to screening women specifically who may be at high risk of breast cancer. Unfortunately, they focus also specifically on BRCA mutations, regardless of the fact that we know there are many other mutations now, and they focus specifically on women. So even though men carry BRCA mutations at equal rates as women, unfortunately, they are not eligible for testing at no cost under the USPSTF and therefore under the Affordable Care Act. So that might be something we're going to talk about a little more today, is how we can increase the number of people who are eligible for testing. I'd also like to talk about the healthcare providers, and as Brandy noted and some others noted, some of the providers don't have the expertise that they really need. And so my next question to the group is, do you have suggestions or thoughts on how we can go about improving provider knowledge base around this, and we're talking from the ground level, primary care to the OBGYN, or should they not be involved in this? And I think that can be problematic. So how potentially can we improve the knowledge base in these more generalized professionals, as well as in those with more expertise? And then I'm actually quite interested, and maybe we'll circle back later, to talk about how we can increase access broadly. As Heather mentioned, we're now finding that these mutations, or at least Lynch syndrome and BRCA, are actually more common than birth defects. So why is it that we have newborn testing and we don't have testing for these hereditary mutations? And maybe we can take a look at how the process for newborn testing evolved, and whether or not there is room for us to start advocating for that. But let's start first with the providers. So Heather, you work in a major cancer center, you work closely with providers. What do you see in regard to the patients that are referred to you, and whether or not their providers have the knowledge they need? And if they don't, what can we do to help facilitate improved knowledge for providers?
So I think providers are trying very hard, but I think they have a lot to do in very little time. And unfortunately, family history gets put by the wayside, or has less than 3 minutes given to it during a standard primary care visit. And so this is a real challenge. And I think automating things is probably, first of all, training. We have to insert this in the training very early. So we do a panel with our medical students at Ohio State where we have patients who have hereditary cancer syndromes talk about their experience, their family's experience, and all the options that they have for prevention, life-saving prevention and treatment options once they get the diagnosis. And we hope those stories resonate with them when they go out in the world. But I don't think we've done ourselves much of a service by changing these guidelines all the time. They're very difficult to have them memorized, even if you work in this field. So I'm not sure how we can expect primary care providers to have them memorized, especially when they change all the time. So I think that maybe utilizing the electronic medical records better to help flag for the doctors patient meets guidelines and needs a referral in a more systematic way might be a good approach to help them.
That's a great suggestion. You know, there's been a lot of talk about electronic medical records in recent years and some of the challenges, but there's certainly promise that comes with that as well. Jennifer, what are your thoughts on educating providers and getting them up to speed?
I mean, obviously, improving their training, starting integrating medical school curriculum would be a huge step. A lot of providers are either affiliated or an academic medical center where there's probably molecular professionals on staff, even if there is a program there. If they're smaller, there's probably a pathologist around who could also. And I do think they're utilized who could help educate other providers. Molecular pathologists are the ones in the CLIA labs doing. However, they rarely interact with, they don't often interact with treating the physicians ordering the. I think trying to build and lines of communication between that team might also help educate some colleagues at their institution as well.
That's a great point. So every hospital has pathologists. You may not have genetic counselors, but pathologists can also be subject experts when it comes to the genetics. Nikki, you know, your community specifically is dealing with biomarker testing, and you rely on your pathologists as well as your oncologists. So you may not be dealing as much with your primary care doctor, but where do you see a role for improving education and awareness in the community you deal with?
Well, I was gonna bring this idea of educating the providers back to when I introduced myself. I mentioned this pan-cancer effort around consistent testing terminology, and it's all about using consistent language to talk to, for providers to use that consistent language to talk to patients about testing. So whether we're talking about biomarker testing or whether we're talking about genetic testing for an inherited mutation or genetic testing for an inherited cancer risk, that we're using these same terms so that there's less confusion on the patient side. But there's also a role for all of us to play in educating providers about what those terms are, to simplify their lives and to empower them to have better, I guess, shared decision making and better education overall with their patients and the family members. So one way to do that would be, you know, meeting with multidisciplinary teams. We've had requests from different providers to present on this work that the working group has been doing on consistent testing terms, present on that to tumor boards, so that all of the members of the multidisciplinary team can hear about the working group's recommended terms and why it's important to use consistent language. There are 5 medical societies that are participating in this working group, including the American, the ACCC, so the Community Cancer Centers, Association of Community Cancer Centers, AMP, which is the Association for Molecular Pathology, ASCP, which is the American Society for Clinical Pathology, the National Society for Genetic Counselors, and ISLAC, which is the International Association for the Study of Lung Cancer. So all of these societies have recognized the value of this and are willing to bring this information down to their members. I think trying to work through through those sorts of mechanisms is a great way to reach the provider community with information that could help make it easier for them to communicate to their patients about testing.
That's great, and I know that the consistent terminology working group has many different societies and organizations involved, and I do think, you know, working with the professional societies obviously has great value. I think Heather mentioned, working with the med students. I know that in the ovarian cancer space and probably some other spaces, they have programs such as Survivors Teaching Students, and going in and talking to those residents and new doctors, I think can be so useful. So, Becky, you're looking at this from a little bit different perspective through Guardant. What do you see through your lens, and how it can apply?
Yeah, I think coming from an educational background and a background where I worked with medical students in the healthcare setting, there's definitely a passion for education within my Med Affairs team at Guardant. And so we've carried that forward. I think one thing I want to say is repetition is key. You can't just hear these concepts once and understand them. So for a busy clinician who sees patients with 5 different cancer types, repetition about a complex topic is important. And so it takes the patient, it takes the other healthcare providers, it takes professional societies, it takes advocacy, it takes other colleagues to help educate the healthcare profession. And I think industry can play a role there as well. And so one of the things that we've done at Guardant is proactive outreach to clinicians at the time when they get their first test result, as well as when they get an actionable finding, like an actionable biomarker that would trigger a targeted therapy. Because I think that is when there is an educational opportunity, because it's their patient at stake at that point. It means something to them, and they're very likely to remember the education that we provide when we provide it in that real-time setting, in that real-time situation, and it impacts their patient. And one of the interesting pieces of data that we have pulled recently is that those physicians who get that type of interaction and respond are more likely to order the test again. And the reason that's important is because I think one of the reasons doctors don't like to order comprehensive genomic testing is because it's complicated, and they don't want to order a test that they don't understand. So if they feel confident in it, they understand what the limitations of the test are, and they can interpret it for their patients, they may be more likely to order it, which just translates into more patients getting the right testing and the right therapy. So I do think that industry can play a really important role in that educational process.
I love that. I love that the clinicians hear from you and get guidance. I think that's such an important aspect of this process. So, Brandy, you're coming at this from a little bit of a different perspective, and I was interested, especially because you said you don't have access to genetic counseling, at least not in person where you are. So, what do you see as an opportunity or a path to educating providers in areas like yours to increase their knowledge around genetics and how it might be utilized to improve patient care and outcomes? Brandy? You there, Brandy? Heather, can you hear me? No, I can't hear anybody.
No, I can hear you, Lisa.
Oh,
Oh,
sorry.
okay.
Yeah, we
I
can
think we
hear
might have
you.
just.
I think.
All right. I think we
Yeah,
just lost Brandy.
Yeah.
So her picture's static. So we'll come back to Brandy. So one of the things I wanted to mention based on Brandy's story was no matter where you live in the country, you do have access to genetic counselors. And in fact, some health insurers require genetic counseling prior to a genetic test. Cigna, for instance, was one. And because of the way things have evolved so much, telegenetics is actually quite commonplace now. So most people who live in areas that maybe not have a genetic counselor in person can certainly access them via telephone or Skype or virtually in some way, which seems to be what everybody's doing now with COVID. So the genetic counselors were ahead of their time, although we also know that there are some barriers to access to genetic counselors, which we'll probably talk about later in our breakout groups. But I want to talk about what happens now after people have testing. So, you know, an individual goes, they get a test, and it's determined that they carry a mutation that puts them at increased risk for cancer, or they go and they have biopsy, and they are found to have a targetable mutation, where, you know, we might have a targeted therapy. Are we seeing access across the board for people, or are we seeing disparities? Because there's a lot of talk about disparities right now, and not just based on the color of your skin, but also socioeconomic, rural versus urban. We definitely have different communities out there that are affected differently and have different types of access. So, Heather, what's your perspective on the access to the services that the people need after they have the testing? Because obviously that's the next step. This doesn't end when somebody gets tested.
I think that's a great question, Lisa. And just to follow on with a point you just made a minute ago, some of the insurance companies that do require genetic counseling before genetic testing all are for inherited mutations, not for the biomarker testing, just to make sure that everybody is aware of that. It is, genetic counseling is not required before biomarker testing. So what access do patients have after the testing? So that's sort of the most important part, right? Once you know that you have one of these inherited cancer gene mutations, can you get access to the intensive surveillance and prevention options you need? And what is your insurance coverage going to be like? Similarly, I think, and some of the other panelists will talk about, if you are found to have a biomarker that has an actionable therapeutic, is that only available in a clinical trial 3 states away, or is that something that you can access locally? And so these issues cut across both the biomarker testing and the inherited testing, genetic testing for inherited cancer syndromes. I have found this to be less of a problem in the last few years, but they are expensive things. You know, telling someone they need an MRI annually for their breasts is a very expensive test, and we've had trouble with coverage for that historically. There are foundations who step in simply to help cover access to MRI for some of our BRCA mutation carriers who need that test. Getting a colonoscopy once a year can be challenging for our Lynch syndrome patients, and that's an expensive test as well. I have found that, you know, if we document mutation and the guidelines in the medical record, generally you can get coverage for these screening tests, but it often takes some fighting back and forth with the insurance companies to get them pre-authorized and to show that you're following national guidelines. And so there's a lot of effort involved on both the patient and the provider's part. And to think about having to go through that almost annually it is a real challenge. But that seems to be the only way to tackle it, sort of one procedure and one patient at a time.
Right. And I know through our experience at Force, we've encountered very, very similar issues. And even though the insurer might agree to cover that MRI or that colonoscopy, it can be applied to a person's deductible. And if they have a high deductible plan, they're paying a lot of money out of pocket. So yeah, and I think that also impacts access, obviously, because if a person can't afford it, then they may not get it. Jennifer, I know you've worked with a number of different organizations that deal with different communities. What has been your experience with access to the necessary services or treatments after somebody has their genetic testing or biomarker testing?
Yeah, so I think, back to something we were talking about earlier around awareness, just making sure the providers that they're working with are aware of opportunities, not just clinical, drugs that have been approved by FDA, but also clinical trial opportunities as well. And I think when you tie in diversity in clinical trials, there's a huge gap there in terms of minority recruitment and enrollment. And I think as well as in the researchers themselves and having a diverse research base of scientists that are planning and recruiting for these trials. So I would really like to see an effort in the research side to both in terms of the professionals conducting the research and as well as the participants. And then box in terms of access, even a biomarker that is associated, it could be challenging that therapy if you didn't have a test that might have been referenced in the. As we're moving more toward panel somatic testing of some labels are very type of test, and I have heard where then the coverage for the IP is challenging unless the patient has done with the on-label diagnosis, and then insurance won't cover it because they've already one. So I have heard that as a barrier after a test as well.
Interesting. Okay. So again, I think Jennifer's connection is not great, but she's talking about and made a great point how for targeted therapies, certain tests are approved to go along with certain therapies. And if you don't have the right test, or if you've previously had the test and you need to have it again, that may be a barrier for some people accessing what could be the appropriate therapy for them. So it is a big issue. We've definitely seen this with private payers as well as insurers like Medicare. So Nikki, your community probably has some experience with this as well. What is your perspective on barriers to, once somebody has that testing, barriers to getting access to the appropriate therapies, or the therapies that may be the newest or the best for your community?
Yeah, well, without a doubt, there are barriers to the testing still, even in lung cancer, where you have, I think, 9 targetable mutations right now listed in NCCN, which is more than any other cancer. So the barriers to the testing, the need for more clinical utility for insurers to pay for it, Medicaid isn't paying for comprehensive biomarker testing or testing for multiple mutations at once. And then access to the drugs. Also, I probably need my public policy colleague to speak about that more specifically, but I think that a lot of companies create programs to make access to drugs when insurance isn't covering it more, I guess, possible for people. But a lot of people might not know about those programs. They have to work through their doctor's offices to apply sometimes, so there could be paperwork barriers. But I mean, we're talking about barriers that are still existing on both sides, testing and probably access to drugs as well.
And you make a great point, and I hope all of our advocates know that all of the pharmaceutical companies do have patient assistance programs, and the labs for that matter. So if finances are an issue, do not be afraid to reach out for yourself or for people that you're working with, because there are resources out there, and all of our organizations work to make sure that individuals who need access get it. So Becky, from Guardant's perspective, what do you see differences in the folks coming to you for testing, and then do you know what happens afterwards?
Sometimes we hear what happens afterwards. I would just echo what Jen and Nikki mentioned about access to drugs based on the test that's ordered. The CDX component of things does sometimes limit patients from getting drug because they didn't get the right test. I also think the issue of what happens after test results report is time, how much time elapses. A patient might eventually get the right drug and get approval from their insurance company, but it might take them 4 to 6 weeks to get that approval. And in that time, they're not being treated, and causes a lot of anxiety on top of everything else. And so I think the timing issue can't be minimized. It's definitely a barrier we see. We want patients to get not just to get the right genetic test and to get the information, but then to get on the right therapy quickly. I think that's a big piece of it.
Yeah, and your point about point about timing is important because obviously there could be progression during that time as well. Sorry, Nikki, you had something?
Yeah, actually, Becky raises a super important point, which is that a lot of patients where they're waiting for the results from the comprehensive biomarker testing, because that can take, especially when it's done with tissue-based testing, it can take sometimes up to 1 month to get the results back. And doctors will make decisions or to put patients on a chemo or maybe an immunotherapy because maybe the patient is super stressed, and is asking to be put on something right away, or maybe the doctor just thinks it's the best route to put someone on something until they get the full results back. But that can cause a lot of trouble down the line for their care, for their access to clinical trials, if they're put on something that's not the right treatment for them. And so when we're talking about access to drugs, actually that is one of the biggest barriers, is the waiting for the results, and then decisions that happen as you're waiting for the results, and improper decisions that can impact the patient's care.
So timeline can be a big issue. I know in hereditary cancer, it's possible to expedite test results, but I don't know if that is something that is done routinely or even possible for biomarker testing. So I think that could be something that we talk about in our breakout groups. So Brandy, are you there?
I'm here. Hopefully I don't freeze
Great.
again.
No, okay, I'm glad. So I want to give you an opportunity to weigh on our last couple topics, and then we're going to wind up. But we talked a little bit about disparities, which we'd love to get your perspective, because there are disparities beyond race. Rural treatment versus urban treatment, community cancer setting versus large cancer centers, access to specialists, that type of thing, and access to testing as well. So I'd like to hear just from your perspective what you've encountered through your work with your foundation and personally.
For sure. So like I said, I'm from Nebraska. So we have, it takes 8 hours to get from one side of the state to the other. And I think you'll find that a lot in the Midwest. So we have, in Omaha and Lincoln, we have genetic counselors, but Lincoln West, so for 6 hours, you will have nobody. And for so long, there's been a really big push on only genetic counselors seeing patients. And I've seen my fair share of genetic counselors. I actually would love to be one someday. But I think that we need to make sure that patients can be met where they are. And if that's when they go in and they talk to their primary care about getting a flu shot, if that's the opportunity to have the conversation about you may have Lynch syndrome with an 80-year-old rancher, I think that's what we need to do. So just meeting patients where they're at. Like you guys said earlier, I think it was Nikki said something about consistent language. I think that that's really important when it comes to patients, that they hear this over and over and over again when they go to their primary care, when they go to their OBGYN. If everyone is raising the same red flags, they might think twice about, maybe I do need this test. Or if they're at Thanksgiving and they hear, great Aunt Sue had ovarian cancer, and then her daughter had something, and grandma had colon cancer, and maybe start to piece all that together. Consistently bringing this up and not just having it one specialty that's going to talk about it. And then in terms of, we were talking about educating providers earlier. I think it's really important to keep it simple. A lot of times when we throw out the word genetics, I think that a lot of providers will be like, that was my least favorite subject in school, and I don't want to talk genetics, and I don't want to talk statistics. We can keep it really simple, and like in an OBGYN, how would it alter their medical management? It could be as simple as birth control. And I think that if we keep the message that simple, it makes this a lot less daunting to talk about, and we'll be able to identify more high-risk families and be able to do a lot more. So I think I touched on that last piece. And then one other thing I wanted to say is I think genetic counseling is a process. It's not just a test. And so often we think that it's just we're going to offer this test. We're going to do, pre-counseling, post-counseling, and then we send the patient off into the world. It's much more than that. This is we've been studying this stuff. I think Dr. Lynch started in 1960 doing this work, but we're still learning a lot, right? I think PALB2, they just added ovarian cancer as a risk to that gene. That kind of stuff is ongoing. We might see colon cancer added to a BRCA mutation, in years to come. I think we need to keep patients up to speed, and we need to keep providers up to speed. It's not a test, it's a process. And feelings change along the course of all of this. So, I was tested when I was 19, and how I felt at that moment was different than when I was 21 and had a baby. I was ready to have a bilateral mastectomy because it wasn't just me anymore. I had somebody else to take care of. And then, as I approached 35, the way I think about this is a lot different, thinking about menopause and, I know my grandma struggled a lot. She felt guilt for passing on a mutation. So I think just touching people where they are at various points and understanding that the people's feelings towards this will change throughout the course of their life as well.
Those are fabulous points, Brandy, and it absolutely is true. I know from my own experience as a mutation carrier that it's a journey. It's definitely not static, and genetic counseling, in fact, should be a process because needs change, research changes, and recommendations change. So we are running a little tight on time, so I want to open it up to questions, and I do want to just throw out one other topic that that our audience can feel free to ask questions about, or we could even discuss it during our breakout groups this afternoon. But that relates to genetic protections and genetic privacy. Some people are fearful that the information that is discovered in genetic testing can be used against them in some way, whether it be to impact their ability to get healthcare in the future, or to get life insurance, or disability or long-term care insurance. We have two laws that factor into that. Currently, the Affordable Care Act, which guarantees that you cannot be denied or charged higher rates for health insurance, and then the Genetic Information Non-Discrimination Act, which ensures that employers and healthcare providers, healthcare insurers cannot use your genetic information or family history of a disease against you, although there are limitations to that. So just want to throw that out there because I think it also is a factor for people who are looking into genetic testing. And we'd love to take questions. I think our friends at Prevent Cancer Foundation are going to gather those for us, and then we'll respond as appropriate. Brendan, Taylor, do we have any questions?
They fixed Taylor's audio. I see he's typed a question in the chat box. Maybe we could look at.
I don't see the chat. Yeah.
Want me to read it for you?
That would be great. Thank you.
Okay. He said, healthy 50-year-old female who wants to consider biomarker testing. How do I get started? And would that be a general practitioner test?
Oh, interesting. Okay, so healthy 50-year-old female who wants biomarker testing. So if the individual is healthy, she likely would not need biomarker testing because she has to have cancer in order to have biomarker testing. Biomarker testing is specifically a tissue that is taken from the tumor. So perhaps the individual can clarify whether or not she's specifically interested in biomarker testing for a cancer tumor or hereditary cancer testing, which is much more common or doable in a healthy individual.
Yeah, that's a good point. I wonder if, when I alluded to liquid biopsy maybe being used in the future for cancer screening, if she could be thinking of something like that. Becky, maybe you could tell us what's going on at Guardant with that.
Yeah, so there's several different labs looking at using ctDNA technology to screen at-risk populations. Right now, there's really no commercially available test, but down the road, we hope that there will be.
Great. Okay. Taylor's having audio issues, but we do have another question. And the question is whether or not you should see a general practitioner to start to screen for genetic mutations. So I guess Heather and maybe Becky, we'd start with you too. So where would an individual start if they are interested in being screened for a hereditary cancer mutation?
So I think talking to someone's family doc or a primary care physician is a great place to start. And the other thing you can do is actually go to www.findageneticcounselor.com and look for a genetic counselor near you, either in person or by telephone or video genetic counseling, as you mentioned earlier, Lisa. So you can direct refer to genetics if you have a strong family history, or you can talk to your family doctor about your family history and see if he or she feels that a referral to genetics is appropriate. Either way is fine.
Great. And Becky, do you have anything to add to that? No. Okay. Brandy, based on your perspective, especially because, as you mentioned, primary care doctors are probably the key point of contact, or maybe an OBGYN. Is that where you see most people are starting their exploration into genetic testing?
Yeah, I think it's a good place to start, but I would encourage patients to know that not every doctor knows everything, so second opinions are key. Or I still hear people say, well, I talked to my OBGYN about this and they said I couldn't get it from my dad. And it's like, well, that's not true. So unfortunately, we're still in this world where people have to advocate for themselves. So I think it's a good place to start. But if your doctor tells you no, don't take that as, the be all end all. Keep fighting for yourself if you think you need to.
Such a great point. We also hear many people say, my doctor told me I couldn't get this predisposition to female cancers from my father. And it makes you wonder where the person went to medical school. But anyway, so that actually moves on to another important topic, and that's about the accuracy and consistency of testing. So we probably have different scenarios for hereditary cancer testing versus biomarker testing. So, and Jennifer, I know you have great experience. You work with the Association for Molecular Pathology. So maybe you can speak to how accuracy is ensured. If you have experience with both Germline and Somatic, that's great, but feel free to speak to one, and then maybe we'll ask a few others after you have an opportunity to share.
Yeah, so the ability of a test to or identify a variant or mutation to its analytical validity. There's a federal agency called CLIA, which is improvement amendments that regulates analyticity of tests and the laboratory practice help that. And one example is labs engage in something called proficiency testing, where they'll swap samples to make sure that their test is running correctly and calling a positive, negative, and negative. So there's lots of ways in which laboratories can do that to assure the accuracy of their tests. But an area where there might be variation of tests, and I'm sure in the folks offering cancer testing can relate to or share more about it, is that a hereditary cancer gene panel might vary depending if you get it from Myriad or Invitae or an academic center, that the types of genes that are included in the mutations within those genes that are included in that panel can vary. And that doesn't mean a test is less accurate than another one is test. And so perhaps Heather or Becky could speak to that variability.
And you bring up a good point, and that is with these panel tests, we do see higher numbers of what's called a VUS, or a variant of uncertain significance. And Heather didn't really have a chance to touch on that during her presentation, but that's when the pathologist found a mutation, but they don't know if it actually causes increased risk of cancer. It's something that we just don't have enough information on. And those are definitely more common. And that doesn't mean that the test isn't accurate. It means we just don't have the information to classify that mutation at this time. So when it comes to biomarker testing, though, and I don't know if Becky or Nikki, you want to take this. Are there variations in accuracy? I mean, if you were to take the same sample to 2 labs, is what they find going to be pretty consistent across the board, or is there variation?
I can start, Nikki, and if you want to chime in. Does it sound okay? It will definitely vary, and a lot of it has to do with the methodology that's used. Also, the tissue source, if it's a blood test versus a tissue test, there will be different limits of detection below which a test can or cannot find a mutation. And then different classes of mutations can be more difficult or less difficult to pick up. Your simple point mutation is pretty easy, but when you get into things like rearrangements or fusions, those can be more technically complicated. I think another point to make here is that not only are the assays variable, but in terms of their sensitivity and specificity and accuracy, but also what doctors have the opportunity to order within their healthcare system is vastly different. So a pathology department might say, the test that we're going to do here at Hospital X is this test. You're not allowed to order anything else. And that, if that's the case, that doctor is going to use that test and not maybe have access to a more comprehensive test. And so sometimes what happens is patients only get partially genotyped for some of those biomarkers we mentioned earlier because their hospital has basically dictated what they can and can't order. And usually that's because of this issue. They're trying to control cost for the hospital system when they do that.
And health insurance can play into that as well. They might put limitations on what they'll pay for, which can sometimes affect what the patient chooses to test for. So Nikki, do you want to follow up on anything Becky said?
Yeah, no, that's correct. Certain kinds of things that you're looking for in the cancer for biomarker testing are more difficult to find. And so certain tests are going to be fine-tuned to excel at finding those more difficult things. But not all tests are the same. But it's so complicated, and as a patient advocate, it's not the patient's responsibility to understand that level of complexity. And so you're really relying on the doctor, the pathologist, and the team that comes together to support the patient to make sure that they have the right process in place, so that if they get this kind of a result back on a test, they have kind of like a backup plan to like double check whether or not that's accurate or not, or and so it's a complicated world out there for biomarker testing. The science is advancing so quickly in so many cancers. The scientists and companies like Garden and other labs their expertise is so far ahead. And so it's our collective responsibility to make sure that our healthcare providers are staying at that same pace of science so that patients have access to the right precision medicine for them.
Thank you. So I do want to clarify that as Nikki and Becky were talking, what they were referring to is biomarker testing. And of course, the results are only as good as the specimen submitted or taken by the doctor. There is pretty good consistency, actually quite good consistency across the board for testing for hereditary cancer predisposition. Those tests have been around for quite a while now. So if you get a true positive result that they found a mutation, the likelihood is it's very accurate. And you know, if you get a true negative result, if there's a known mutation in the family and you test negative for it, that's pretty accurate. Where we have the in-between is those variants of uncertain significance, and many times those are reclassified. And that's important because the lab might follow up with you or your genetic counselor or your provider if in fact more information about that mutation is found. So we need to wrap up now. There was one final question I see in the queue here. It's a very easy one, and it says, is the National Cancer Institute, so NCI, information on genetic testing a good resource? And yes, NCI is a fabulous resource. It's not the end-all be-all, but it's certainly a good place to go for reliable evidence-based information. And then there are a number of other organizations that you can turn to, and I suspect that Prevent Cancer Foundation will share some resources with you as, you know, after this workshop, so that we can help you find more expert information and more detailed information on these topics. So I think we're going to be moving to a break now, and we're going to be breaking into our discussion groups, our breakout groups. We are breaking into 6 groups. You will be provided with a link to your breakout group. We're going to take a few minutes to get everybody organized, and you should see that link in either your email that came in or in on your screen or chat box. So thank you for your patience while we switch over, and we look forward to connecting with you in our discussion groups. We'll talk to you soon.
Hi, can everyone hear me? Great. Yeah, so just to kind of touch base on what Lisa was saying, we will be transitioning into the breakout soon. What I'm going to do is drop a link into the chat for all of you to follow. And what we're going to do is tweak the time frame a little bit. So instead of having a 15-minute break, we're going to drop that to about 10 minutes or so. So I'll drop the link in the chat, and everyone can join into their breakout session at 2:55. And you won't have to do anything. You'll be automatically sorted into your breakouts. So everyone go take a break, walk around, stretch, get some coffee, and we'll see you in your breakout sessions at 2:55.